Good afternoon. My name is Corey, and I will be the conference operator today. At this time, I would like to welcome everyone to the National LAN event. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Lindsay Kirsch, you may begin your conference.
Thank you, Corey. Good afternoon, everybody. Thank you for joining us for the National Learning and Action Network, or LAN event. We're very happy to have you with us today as we discuss this very important topic of mastering hypertension to achieve heart health. Again, my name is Lindsay Kirsch. I'm a program specialist with Pelican and the Quality Innovation Network National Coordinating Center, or the QUIN-NCC. So a few reminders and housekeeping items before we get started with our content today. Thank you for joining us in the WebEx Event Center. You will need to access your registration confirmation email and unique registration ID to log into WebEx. My colleague, Karen Tenkate from QSource and the QUIN-NCC will be monitoring our WebEx chat board. So please be sure to participate as we go along and feel free to ask your questions in chat. Slides, resources, and the recording from today's session will be posted on qioprogram.org under the News and Events tab, and some of our resources have already been posted. Karen will get that link for you all in the chat as well, so take a look there for that. So we'll start by reviewing today's agenda. First, I will go over the continuing education, or the CE details. Then I will introduce each of our speakers today. Cynthia Pannon with the Centers for Medicare and Medicaid Services, Judy Hannon with the Centers for Disease Control and Prevention, Meg Metter with the National Association of Community Health Centers, and Dr. Larry Garber, Reliant Medical Group and previous hypertension control champion. There will be multiple facilitated discussion portions during which we will address questions posed in the chat and via the phone line. If we do not get to your question right away, know that we are compiling them, and we will attempt to address as many questions as possible during the facilitated discussion portion. And finally, I will wrap up with a reminder to complete our post-event assessment and a plug for upcoming calls. I'd like to take a moment now to remind our participants about the purpose of this important series of learning and sharing events. Without reading all of the content on the slide, I'll just mention a few points here. Our audience is very broad and inclusive of a variety of healthcare provider types, partners, and patients. Our purpose is to offer virtual learning and sharing events with a focus on ideas and concepts related to healthcare quality improvement. Our expectations are we would like to ask that you think of actionable ways to implement the ideas and concepts presented today and make a commitment to share the information with your own teams. And finally, we are always open to new ideas and suggestions for topics to bring to this audience. So please feel free to send your ideas through the chat and or through the post-event assessment. And to address the direct purpose of today's event, we will prepare healthcare quality improvement professionals to identify and implement effective healthcare strategies by exploring promising practices to achieve heart health by managing hypertension. And we're hoping to make this as interactive as possible, which can be challenging given such a large audience. So we ask you to commit as individuals to be attentive, active, and actionable, thinking about all the ways the content is relevant to your work and priorities. We welcome your active participation by clicking the green check in the WebEx application. You can click the conversation bubble, choose yes in the drop-down menu, or you can also just tap yes in the chat box, which Karen is monitoring. So we're very excited to be offering continuing education credits to all attendees for participating in today's session. We offer credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer certificates of attendance. So should you have any requests for additional accreditation types, we welcome those suggestions as well. Your options are to put those in chat or through the post-event assessment after the call. In order to apply for continuing education, you must have attended this entire event, complete the post-event assessment upon exiting this WebEx session. Note that the CE evaluation can only be accessed by following the application site hyperlink at the end of the post-event assessment. And if you have any needs for technical assistance related to the CE process, we'll have you email Nikki Rosellis, and Karen will post her email in chat. This is a disclaimer from our partnering provider, CRW Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants, and you may reference the slide for the full CE statement. And again, the slides are under the News and Events tab of the QIOprogram.org site. This activity also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians. To follow are the accreditation statements for those entities. And another disclaimer, we'd like to report that the planners and faculty for this event, CRW and Associates, and Intelligent do not have any financial relationships to disclose, nor was any commercial support received for this activity. And these are finally our disclosures of financial relationships for your reference. So again, you must participate in the entire live activity to claim continuing education credit. The slide has contact information for questions related to this activity. And again, Nikki Rosales is a great contact if you have any other questions about the CE process. Okay, so in an attempt to get an idea of what types of organizations are represented on this call, we are going to invite you to respond to a poll indicating where you are working. We'll have WebEx open the poll for us. We're wondering, we have CMS, home health agency, hospital, nursing home or skilled nursing facility. Are you a patient, family, or caregiver representative? Pharmacy or pharmacist, provider practice. Are you with a QIO or other? So it looks like about 20 seconds left to complete the poll. So, okay, about 7 seconds left. And after that, we will load the results just so we can have an idea of who is on this call. So while we're waiting for those poll results to load, I'll review the session objectives. By the end of the call today, you should be able to select one or more evidence-based blood pressure management tools, identify and support high-impact changes a physician practice can implement for improved identification and management of high blood pressure, explain the role of self-measured blood pressure monitoring and effective care of hypertension, and describe effective practitioner-patient approaches to increasing medication adherence. So it looks like the majority of our participants are from the QIO program and some others as well. And a good number of hospitals, providers, and practices, which is great. So thank you for responding. You can also, if you missed the poll, you can put it in the chat. Oh, we've got one of those. That's great. From ACOs, health departments, Medicare Advantage plans. Wonderful. Thank you so much for letting us know. We really appreciate that. So now I would like to introduce our first speaker. Cynthia Pannon is a program lead and the cardiac health subject matter expert in the Quality Innovation Network Quality Improvement Organization program at CMS. Cynthia will talk about the efforts underway at CMS around achieving heart health. So Cynthia, the floor is yours.
Okay, hello everyone. I'm going to flip over to the next slide. Hopefully you all can see the CMS strategic goal slide that I put up first. Lindsay, does that come up on your end?
It does.
Okay, great. So I have control. I want to talk briefly to you all about the CMS perspective around why improving cardiovascular health and blood pressure control are important to us, and show you some of the work in progress to date that CMS sponsors. The work aligns nicely with our CMS strategic goal and the need to put patients first. Our Centers for Medicare and Medicaid Services strategic goals involve empowering patients and doctors to make decisions about health care. We're ushering in a new era of state flexibility and local leadership. We're supporting innovative approaches to improve quality, access, and affordability. And we're doing all that we can to improve the CMS customer experience. This next more detailed slide, I'm not going to go through this line by line, but I just wanted to show you how at CMS we're taking these strategic goals and what we mean by them in a general sense in terms of how we're going to do the work that we do to fulfill these goals. More specifically, I just want to point out how we're going to use these strategic goals and achieve heart health. We have our 14 Quality Improvement Network QIOs, and we're forming partnerships with providers, clinicians, communities, and anyone else who's interested in helping us do the work that we do. One of the things that you'll see in this slide, and there's a couple of things and important terms and phrases that stand out among the goals, and they include empowering, decision-making, local leadership, innovation, and customer service. With our 14 organizations, our QIOs, we are working with them to facilitate and achieve the goals. And I want to point out a few items on the slide. And that is, we are working to empower patients to take ownership of their health by advocating for patient self-management of their heart health, and specifically around blood pressure control and the self-management goals related to that. Our efforts around the customer experience include providing patients and clinicians with the tools and information that they need to make heart health decisions that work best for them. We're no longer in the trying to get out of the business of being so prescriptive in terms of what we tell clinicians and patients what they should do. That may not work for them. We want to make sure that people are empowered to do what they need to do at the local level and at the clinic and patient level, so that they take responsibility for the health and needs at the local level. This next slide is just a snapshot of how we're aligning with the Million Hearts Initiative, and that we are focusing on all of the ABCs, appropriate aspirin use, blood pressure control, cholesterol management, tobacco use, screening and cessation, and also disparities reduction, clinical quality reporting on the measures, clinician engagement as much as we can do that, maximizing patient and family, stakeholder, and partner engagement. All of these things work together in terms of what we are supporting to improve heart health. This next slide is just simply give you a snapshot. We are working also to make sure that anything that we put out, depending on the target community, that it accounts for race, ethnicity, language, literacy, anything that will reach down to that target community that we can use to make a difference. And also, since I do manage the Home Health Quality Improvement National Initiatives that are known as HHQI, I always try to make sure that there is cross-project collaboration so that what the patients are receiving in the home matches what we're doing in the physician's office and anything else as far as our heart health and blood pressure control initiatives are concerned. And then also there is a need to focus on the social determinants of health. When we talk about making a difference as far as disparities is concerned, you cannot overlook this. Health disparities is not just about health in certain communities, as I'm sure some of you know. There are many factors to consider if you want to make a difference and improve health, especially as it relates to African Americans and blood pressure control. With our participants, partnerships, and collaboration, when we talk about this, it's important to know that no CMS staff person, myself included, or a contractor can do this work in isolation. It requires outreach and cooperation for others, and we support that. So we're working across various entities, as you can see here, from the physician's office to various agencies across HHS, our partners at the CDC, and any relevant national, state, and local partners. We will work with anyone who wants to work with us. With the progress to date, I just wanted to give you a snapshot of what we've done to date as far as blood pressure control across the Quality Improvement Organization program, where we initially set the target of 65% for both blood pressure control and tobacco use cessation. We found out that the clinicians and the patients monitored, they were already exceeding the target. in 2014. Fortunately, the 2015 data continued to show improvements in both blood pressure control and tobacco use cessation. And we are working on matching the 2016 quality reporting data, and by that I'm referring to the physician quality reporting system data. But that data are not ready to be released yet. It takes time for us to match the outcomes and to measure data with our recruited participants, meaning our clinicians and physicians' offices that we're working with out there. And we will continue to look at the annual quality reporting data under the new Medicare incentive payment system. Also, the progress to date, I wanted to just give you a snapshot of the level of engagement across the country. We have a total of well over 10,000 clinical participants, and that includes physicians' offices, clinics, home health agencies. Total partners and stakeholders recruited to date across the country that are working with us are well over 1,000. And one of the things that we are advocating in our work is the use of a blood pressure protocol. And we have, of all of our clinical participants, close to 5,000 are using one. We don't advocate the use of a certain one. We just say we want you to use one, whatever is best for your clinicians and whatever is best for their patients. Just use it because the literature supports that it does help. As far as our patient impact and engagement, we're touching well over 5 million patients in total throughout our program. And when I mentioned before about the cross-project collaboration, I wanted to touch on our home health quality improvement initiative and the work that's going on there that supports heart health and blood pressure control. We have a number of things that we share, and even though this is, related to home health, we try to create a number of tools and resources that folks can use and modify for their needs. We also advocate the use of the Million Hearts tools and resources as well. But these are tools that can actually be used in the patient's home. And we have what we call a home health cardiovascular data registry, where we have the home health agency submitting data around blood pressure control, and they're submitting other things around heart health. But we now have a blood pressure control rate of the agency's reporting of 72.3%. We also have, for clinicians and any interested parties that sign up, we have our HHQI University, and these are online, on-demand, self-paced, and free courses around cardiac topics that are focused on the home health patients, but can be used for others if you modify the content. And then what we function on our best practice intervention packages. They're downloadable, customizable, and free at homehealthquality.org. That's our HHQI website. So just wanted to point that out. And here is a snapshot of our cardiovascular health best practice intervention packages, and again, a number of tools and resources that can be downloaded at the website. And they're all free. We just ask that people register so that we can track the use. Now, moving forward in our program that we sponsor here at CMS, we, of course, will continue to align with the Million Hearts 2020. And also, we want to really increase our support and help and assistance as far as the cardiac rehabilitation issue is concerned, and with the goal of 70%. I'm not going to go into a lot of details on that, but I wanted to spotlight that. And this next slide about the Million Hearts 2022 priorities, my colleague Judy Hannon is going to go into more detail on that, but I just wanted to put that up to let you all know that this is something that CMS is passionate about, and we're very supportive of the work that you will hear about as we go about today. And just very briefly getting into the cardiac rehab issue, since my time is running short, I will quickly go through the next couple of slides. And I just want to emphasize that while we want to work to prevent a heart attack and stroke as far as prevention goes, it may not always be possible, and in some cases it may not be possible at all. So we want to ensure that the clinicians and patients are aware of the cardiac rehab benefits, especially in cases where a heart attack could not be prevented, because the risk of a second heart attack can be lowered by participating in cardiac rehab. And just to make note for you, there is a brand new CMS covered benefit for exercise training for patients with peripheral vascular disease, a service those patients can receive at the cardiac rehab programs across the country. So that is something that we hope that the uptake increases for that. Also, just to briefly mention about, again, the goal of 70% participation rate when the current participation rate is hovering just around 20%. And also to point out that the participation rates are lower for persons of color, in particular African Americans, the elderly, those with additional comorbidities, and those of the poor and low socioeconomic status. And then also there is geographic variation across the country. And it's probably, many are just thinking that is an access issue. The cardiac rehab programs are not everywhere, and sometimes patients are having difficulty getting to the sessions. This slide here, I'm just going to quickly go through. It just gives you a snapshot of the breakout by race and ethnicity that we're sad to see that the uptake is so low for people of color. This just gives you a graphical snapshot of what that is. Again, same thing, eligible for cardiac rehab and initiated. Again, the rates for people of color are low. And this is a graph that the roadmap, and Dr. Janet Wright had shared with folks in the QIO program and at CMS, and this lets us know that, there is a way to get to the 70% rehab participation. And getting to that target will employ all the strategies that we have seen as being the best practices among high performers, and these include the team-based care, use of technology, ER referrals, systems and registry, also sound care practices. You can't replace that with anything, and making sure that all of the team members are aligned in their messaging in support of the patient. And the use of a patient, family, friends, community supports wherever possible is very important, and we can't stress enough how important it is in reinforcing the message that the importance of cardiac rehab and getting the patient to his or her regular sessions. And wrapping it up, as far as opportunities for action, I think everyone listening in today can play a part in this, and that's simply raising awareness of everything during the course of all encounters with a patient, family members, wherever possible. Use all mechanisms of outreach and education wherever and whenever possible, and ensure that patients who qualify for cardiac rehab or anything else related to blood pressure control and heart health in general, that they start rehab if that's appropriate and complete it. And for anything else, these opportunities for action could be in place for anything that we do and that we advocate here at CMS. And then finally, the resources you'll see here, we have our QIOprogram.org, Million Hearts, our Home Health Quality Improvement.org, and then the Million Hearts Clinicians microsite is posted here. And we ask that you stay tuned that we will soon have a cardiac rehab webpage coming in the fall of 2017. And that's all that I have.
Thank you so much, Cynthia. We really appreciate your insights from the federal perspective, and we look forward to partnering with CMS and all of our participants on the call today and in the future. We encourage our participants to submit questions for Cynthia and her presentation in the chat, and we'll try to address as many questions as possible during the facilitated discussion portions of the call. And it is now my pleasure to introduce our next speaker for the day. Judy Hannon is a Million Hearts Senior Advisor for the Centers for Disease Control and Prevention. Judy will provide an overview of the Million Hearts 2022 initiative and share hypertension control resources and tools. Judy, thank you so much for being here with us today. The floor is yours.
Thank you very much. I'm very excited for the invitation to talk both about Million Hearts and hypertension. I am confident that you will leave with an increased understanding about the opportunities that are in front of all of us to prevent heart attacks and strokes, and that you will hear about some resources that can help you in your efforts, and you'll learn from some real experts about how to improve hypertension control. I have my own disclaimer. These are my opinions, not necessarily those of CDC or the U.S. Department of Health and Human Services. I'm going to quickly just review Million Hearts 2022, the overall goal and framework. Cynthia set it up, and I want to give you just a few more details. And then I will also pivot to hypertension control and resources that we have. The overall aim of Million Hearts 2022 is to prevent 1 million heart attacks and strokes over the next 5 years. It is co-led by CDC and CMS. And works with partners like yourselves across federal agencies and across state agencies and private organizations. I like to think that Million Hearts provides a platform to shine a light on the things that are most important for us to do to prevent the most heart attacks and strokes, and that is a small selection of evidence-based strategies. And it also serves as a learning laboratory. You'll hear from Meg about some interesting learning we did about finding the undiagnosed, and a repository of tools, protocols, and resources for you all to use in implementing these strategies. We'd like to hear from you all also as you have some successes and share those. We know that the only way that we as a nation will meet the goal of preventing 1 million heart attacks or strokes is through the collective and focused actions of a variety of partners like yourselves. By way of background, each year in the United States, more than 800,000 adults die from cardiovascular disease, and about 1.5 million have a heart attack or a stroke. It's the leading cause of potentially preventable death in the U.S., and the cost to the U.S. economy is over $300 billion every year in medical costs and lost productivity. Cardiovascular disease is the greatest contributor to racial disparities in life expectancy among African Americans. It accounts for more than 1 year in the almost 4 years shorter lifespan. And most alarmingly, after there's been 40 years, actually this shows 65 years of a fairly steady decline in cardiovascular mortality, we are starting to see that it is leveling off. And in some small subgroups and in some populations, there's actually an acceleration that for the first time in 65 years, the rates of cardiovascular death are going up. This is extremely worrisome to us, and it makes us only want to double down on the Million Hearts priorities and initiatives. In general, with the aim of preventing 1 million heart attacks and strokes, we know we need to do this by keeping people healthy, by making changes to the environment, by optimizing care so that those with and at risk for cardiovascular disease receive what they need, and improving outcomes for priority populations. More specifically, on the keeping people healthy, the goals we've set are 20%. So a 20% reduction in sodium intake, a 20% decrease in tobacco use, and a 20% increase in physical activity. You can see the strategies on the right. We know that local food procurement policies can enhance consumer choice for lower sodium foods while encouraging more producers to offer lower sodium alternatives. We know that smoke-free spaces and pricing approaches are effective in driving tobacco use down. And there's promising evidence that increasing access to places for physical activity, designing communities and streets with physical activity in mind, and peer support type walking groups can all help more individuals increase their physical activity level. On the optimizing care side, as the goal for Million Hearts 2022, we've upped the goal, the target for aspirin as appropriate blood pressure control, cholesterol management, and smoking cessation to 80%. And as Cynthia was talking about, the increased use of cardiac rehab, target of 70% initiation. And we know we also need to be engaging patients in heart-healthy behaviors, and we're still working on what specifically some of those targets are. As we've been looking at improved performance, especially in blood pressure, and we believe it's true for aspirin, blood pressure, cholesterol, and smoking cessation to some degree, we know that high performers excel in the use of teams, technologies, processes, and patient and family supports. You will hear many concrete examples of these types of strategies as you listen to Meg and Larry later in this event. And there are many populations that have higher rates of cardiovascular disease, and that often leads to increased rates of death and disability in these populations. Million Hearts is calling attention to a few populations to consider focusing efforts on. These are Black African Americans with hypertension, the 35 to 64-year-olds for whom we are seeing some of the event rates rising, both the death rates as well as some of the risk factor rates, people who have had a heart attack and stroke, and people with mental illness or substance abuse. While this is not an exhaustive list of cardiovascular disease disparities, it's our selected list, or sort of a starter set of national priority populations, based on data that shows significant disparity, effective or promising interventions that we believe will address that disparity, and partners who may be well positioned to implement the interventions. As you strive to improve your blood pressure control, I would encourage you to assure that you are making equal or better progress within your African American population. Blacks, African Americans have a much higher rate of hypertension, with almost 1 out of 2 having hypertension compared to 1 out of 3 in the general population. And as we look at the national data, we also, for African Americans, we also see that they are more likely than their white counterparts to be aware of their hypertension and on treatment, but still not controlled. More about that in a few slides. In general, taking a very broad brushstroke, in the 2014 NHANES data, about 75 million adults with hypertension, only 54% of whom had it controlled. Even though we know what to do, and we know that hypertension leads to heart attacks and strokes. If we look at the 35 million who are uncontrolled, we break them down into 3 groups. 16.1 million, or the largest group, the red piece of pie, are aware and they're being treated, and they remain uncontrolled. Again, this is where the majority of African Americans fit. There are also 11.5 million that are unaware of their hypertension, even though the majority of them have a regular provider and have been seen 2 or more times in the last year. And the smallest pie, though not really small, there are 7 million people that are uncontrolled. Though they're aware of their hypertension, they are not being treated with medication. There are slightly different strategies to address each of these large groups, and I'll talk just very briefly about what we see as some of those strategies. We know that the use of standardized and simplified treatment regimes, interventions to improve medication adherence, and SMBP with clinical support all lead to better control for those that are already being treated. So there's a huge cadre of people for whom it's known that they have hypertension, they are on medication, and we need to up the ante by looking at their medication adherence, simplifying their treatment regime, adding SMBP, self-measured blood pressure monitoring with clinical support to their care. For the 18.5 million, or the gray and the purple that are sort of untreated, the gray area, we need to find them. That's about finding the undiagnosed. And Meg will talk a little bit about what the National Association of Community Health Centers did with federally qualified health centers to help identify them. An important tool in that is a diagnostic protocol. The current protocol of 2 or more elevated readings leaves a very open-ended loop. How many more are the 2 or more before one decides that they do have hypertension and should go on treatment? We also know that out-of-office blood pressure measurement and the standard treatment protocol can help bring all of these 18.5 million people who are currently untreated into the appropriate treatment. Here are a number of tools that are available to assist in improving hypertension control. If you haven't seen the 2 that are pictured here, the Hypertension Control Change Package or the Self-Measured Blood Pressure Monitoring Action Steps for Clinicians, I would strongly encourage you to go to the website and pull those down. The Change Package is a comprehensive package that goes through the different areas you could potentially focus on to improve your hypertension control and provides both change concepts and tested tools from other providers that they have used in order to get to better control. And the self-measured blood pressure monitoring action steps for clinicians really goes through an entire sort of platform that you might need to consider if you want to start deploying that proven intervention. In addition to those tools, you'll see that we have information about how to find patients who are hiding in plain sight, and we have a number of tools on medication adherence. In addition, there are some other clinical resources and tools that we have. We have cholesterol management and tobacco cessation protocols on the website. There's some information about health IT, including a Million Hearts electronic health record optimization guide that gives you kind of a how to find and use data on the ABCs. I encourage you to check out the clinical quality measures. I think I saw somebody asking about some state or local data. I think it was on cardiac rehab. You can, again, look at this website and see HRSA, UDS data, PQRS data, and HEDIS data on the ABCS's performance. There are other tools on there, too, that I would encourage you to look at. We also have some community resources and tools, some action guides that are for public health practitioners, action guides for health benefit managers, and action steps for employers, again, if you are in those arenas and able to help support what they can be doing to prevent heart attacks and strokes. And you've already heard a little bit about the importance of cardiac rehab, and there's a great cardiac rehab collaborative going on across the nation. Healthy and Strong is a platform of materials that was developed for African American men in the Southeast, intended to help them have communications with their providers about their hypertension. And then I'll call your attention to a number of consumer resources and tools that are available. I encourage you to look at those and use the ones that might be most appropriate. And with that, I am going to, again, thank you for your time. And I know we have a reasonable amount of time to answer any questions you might have about the Million Hearts Initiative before getting to our other speakers who are going to focus more on hypertension control.
Thank you so much, Judy. And yes, you're right. At this time, we'd like to open up the phone lines for questions and comments for Judy and her presentation. We'll spend about 5 minutes on questions for Judy at this time and address as many questions as possible. We'll have additional opportunities to address questions throughout the event, but please feel free to submit questions and comments via chat anytime. So Karen, our chat manager, if you'd like to share about the conversation happening in chat and any questions you have, we could pose to Judy.
Lindsay, this is Karen, the chat manager. We did have 2 questions that relate to Million Hearts cardiac rehab participation in the chat earlier. Lisa Packard asked, is the CMMI cardiac rehab test program moving forward starting in October?
And Cynthia, I may be asking you to help answer that. I'm not sure I'm 100% clear on what the test protocol is.
Yeah, that's another area. I don't work in CMMI, but I can check and see what the status is. I'll do that as we go on through the call, and I'll see what I can find out.
Okay, great. And Lindsay, we had another question from Fran Ott. She asked, do you have any cardiac rehab participation rates and completion by state or region? And I'm thinking that's a Million Hearts question.
Yes, and this is, and I know we do. I will also check while the call is going on. What I can't remember is whether it was recently published or recently cleared for publication. So if it's something that we can share, I will be putting it in the chat. If it's not yet something we can share, just know that it will be coming out shortly.
Okay, great. Thanks. And Lindsay, that's all I had for now in the chat.
Okay, great. Well, just for the sake of time, I think we're going to keep moving along in the presentations, and hopefully we'll have a good amount of time for any other questions that come in chat or any on the phone lines as well. So again, thank you, Judy. Thank you, Karen. It is now my pleasure to introduce Meg Metter, Director of Clinical Integration with the National Association of Community Health Centers. Meg will discuss the Million Hearts Hiding in Plain Sight project that Judy mentioned in Mastering Hypertension. Meg, we appreciate you being on today, and the virtual floor is yours.
Great, thank you so much. So it really is an honor and a pleasure to be here today to talk about our efforts over the past 2 years, as Judy mentioned, to address both undiagnosed hypertension and uncontrolled hypertension. In our Hiding in Plain Sight project, which is a reference to patients with elevated blood pressure and no diagnosis of hypertension. So first I'm going to provide a quick overview of the project and highlight some of our key results and learning, and then my hope really is to leave you today with some practical, actionable strategies that you can take home and apply in your own organization. So first, these were our project partners for the HIPS project. We worked with 11 federally qualified health centers that were affiliated with 4 health center-controlled networks that spanned 5 states. Our target population was approximately 200,000 adult patients. And we targeted these areas because they had high hypertension prevalence and low blood pressure control rates. So initially, we focused on the foundational work of improving detection and diagnosis of hypertension patients hiding in plain sight by putting those systems in place that would yield an accurate hypertension population. We felt this was really foundational work that allowed us to then focus on interventions to improve control and ultimately health outcomes, which was then the focus of our year 2. This is just another way to view the sequence of the work we did. So one of the things that we discovered is that past efforts and protocols around hypertension seem to be inward and focused only on management. So even in existing guidelines, there's really no clearly recommended path to diagnosis that ensures patients reliably move into being managed. So our focus was developing processes to identify patients with potentially undiagnosed hypertension, and then critically to engage these patients to come in for a blood pressure check, and then finally to establish clear parameters around diagnosis. So I know Judy mentioned this as well. So these steps are then all built into how health centers address blood pressure control in year 2. This is really the how of each of our project years. So for year 1, as I mentioned, we worked on undiagnosed hypertension and really specifically on developing workflows to address undiagnosed hypertension, engaging patients in care, and of course, timely diagnosis. So there's not a lot of evidence-based strategies on undiagnosed hypertension in particular, so a lot of our work was discovery and proof of concept. We came up with an algorithm or criteria to identify potentially undiagnosed hypertension patients, and then our health centers implemented those algorithms into their workflows, both at the point of care and then also through population health management interventions. So for year 1, I know Judy actually had it on her site as well. There's a link here to the Undiagnosed Hypertension Change Package or Hiding in Plain Sight Change Package. It's also available in the chat box. For year 2, we really focused on blood pressure control. As I mentioned, we had an ambitious target that nearly caused people to fall out of their chairs when we first mentioned it. But as you'll see as I get further into the presentation, this 10% improvement goal was within reach. We focused on applying those evidence-based strategies Judy mentioned in the Million Hearts Hypertension Control Change Package, and then deploying strategies in each of those focus areas. So it's broken down into focus areas that are key foundations, and that really means training, policies, protocols, EHR configurations, those sorts of foundational things that you need in place in order to then focus on population health management and individual patient support. So specifically, we did a lot of examination of our current workflows and then identified the range of potential enhancements, prioritized those into a realistic set of ideas to focus on, and then really, looked at what evidence existed around those. Let's look at some of our outcomes. This slide shows the cross-sectional rate of potentially undiagnosed hypertension. So basically, we used that algorithm that I mentioned to catch patients in the net who qualified for it. And when we did that, we identified about 8.6% initially who were potentially undiagnosed. And over the course of the project, there was a decrease that was actually statistically significant though small, and there are some important factors that would need to be further examined to understand the data more completely. One of the things, for instance, is 7 of our health centers actually had substantial increases in their patient population during the project timeframe due to Medicaid expansion. So this was a QI project, but it would be great to do some further research to analyze these data. In addition to that cross-sectional measure I just mentioned, we actually also followed a cohort of patients using 8 of the 11 health centers' data. And this allowed us to really look at a population of patients and follow them forward over time. So we started in January of 2015 with that pool of patients we initially identified as undiagnosed for hypertension. And then it allowed us to sort of understand more clearly how our algorithm really works in terms of identifying true hypertension patients. Our results were that close to 2/3 returned for a follow-up visit, and then of those 2/3 that returned for a follow-up visit, about 1 in 3 subsequently received a formal hypertension diagnosis. So this is a summary graph of our blood pressure control progress from January 2015 to June 2016. And so you remember I mentioned that we were, our health centers were, about to have a heart attack themselves when we mentioned the 10% improvement goal, but it actually was within reach. So collectively, we moved our patient average, so looking at patients as the unit of analysis, from 54.6 to 58.3, and that represents a 6.7% improvement. Then we used health centers as the unit of analysis, and our improvement was almost 9% on average, so very close. And we found that 2 health centers actually exceeded the 10% goal as of June, which was the formal project end. However, the health centers were so excited about this project, they continued to monitor their data, and we know at least 3 more researchers exceeded 10% by July. So I think the takeaway from this is, and what's so exciting about this is, if health centers, and particularly these health centers, who have some very challenging underserved populations, from Appalachian coal miners to inner-city African Americans to migrant farm workers and refugees, if they can do it, then other healthcare organizations can do it. So we also thought it would be interesting to follow a cohort of patients who were diagnosed with hypertension and whose blood pressure was uncontrolled at baseline. So we followed these patients forward also to take a look at what their average systolic blood pressure was across the project time frame. So since baseline, the average systolic decreased 8.4 millimeters of mercury. And to put that into context, studies show that lowering systolic blood pressure by 12 to 13 millimeters of mercury reduces the risk of stroke by 37%, heart disease by 21%, reduces death by cardiovascular disease by 25%, and overall death by 13%. And our highest achieving health center in this regard actually reduced their average systolic blood pressure by over 14 millimeters of mercury. So this doesn't necessarily mean that these patients achieved control, but it means that they reduced their risk significantly. So similarly, again, looking at the same subgroup of uncontrolled patients in the diagnosed hypertension cohort, there was a 4.1 millimeter of mercury reduction in diastolic blood pressure. And in doing some data mining, of course, would really help us uncover what's moving the average down and for whom, and what the common characteristics are for those patients whose GPP has not gone down as much. However, similarly, we know that lowering diastolic blood pressure by 5% reduces risk, by 5 millimeters of mercury reduces risk of stroke and heart attack significantly. So this was really our celebration slide. Our project included 76 health center sites at those 11 health center organizations. And these are the health impacts we had overall. So the numbers are actually conservative because they're only based on achieving control and don't take into consideration those reductions in systolic and diastolic that I just showed you. These calculations were based on the Health Partners Institute's Community Health Advisor estimates on the modeled effects of improved blood pressure control on heart disease and stroke outcomes. And there's actually a link if you're interested in going to the site and trying to calculate your own program's achievements. You can do that. We also took a look at costs, again using that same tool, and we estimated the cost impact of $2.2 million in medical costs averted. And again, this is conservative as it only considers patients whose blood pressure was brought to control and not just lowered. So if you think you can't make a difference with just a small cohort, small amount of providers doing this work, you really can. So let's take a look at some about how the results were achieved. So there were some really important insights that we learned in this project based on some surveys, and I want to share some of those insights with you. So one question that we asked was to have the teams rate the importance of tools or activities in the project relating to project management. And here's what they said. So our monthly learning collaborative call was rated highly. We all know that getting together with your peers and doing that kind of cross-learning, cross-fertilization is really important. Another really important tool that people called out was doing run charts, and you can see that there on the right side. And that helps visualize their project, facilitate their project. It was a great communication tool. And overall, even though they begrudgingly initiated it, really felt it was valuable. So we also asked them about tools they thought were most valuable in helping them identify ways to enhance care processes and outcomes related to hypertension. And these tools rose to the top. So Judy already mentioned the Million Hearts Hypertension Control Change Package, and you can see the quotation by one of our health centers. It was the best tool. It was so simple to understand. It was packed with awesome evidence-based ideas, and that's well summarized. We also used a CDS QI worksheet to identify gaps in our workflow and areas we needed to focus on to meet our 10% goal. So note that the worksheet divides activities, and I'm referring to that portion on the lower left of your slide there. It divides activities into patient-specific, population-oriented, and foundational work. So for those interested in learning more about this tool, I've also included the link here. And then the Clinical Decision Support 5 Rights Framework really helps us think through what information was most important in prompting the actions that we wanted, how to package the interventions, and at what point in the workflow to implement them through whom. So a lot of times you have some great guidebooks or change packages, but how to translate that into practice is where that Clinical Decision Support 5 Rights really is helpful. So we also asked several questions about high-impact changes or most effective interventions. What this slide really shows is what the highest impact interventions actually did to make them high impact. These aren't the words people use to describe them specifically, but rather how I synthesized what each of the high impact interventions actually accomplished. So most boil down to these categories. Some of these are foundational activities, some are population management, and some are patient-specific care sets. So note that the color coding actually aligns with the worksheet I just showed you. I'm going to go through the next set of slides quickly, but wanted to share with you some real examples of how health centers translated the highest impact changes they identified into practice. This is a foundational change strategy. So obtain the equipment and conduct the training needed to ensure accuracy of blood pressure measurement. Generating data that is trustworthy for clinical action is foundational to supporting clinical nurses to diagnose or titrate medication. It can actually also cause a lot of division between staff as people don't believe or trust readings. This is a simple performance dashboard for undiagnosed hypertension, and what's great about this is that it provides past month and past year, as well as other care teams you can see by the numbers 1 to 5, as well as the health center to benchmark against. This is an extension of providing performance feedback by making data real to people. So one of our health centers felt that they got the most out of people involved in their quality improvement efforts by engaging the data creators, specifically showing staff the impact they're having on their patients. You can even infuse a bit of friendly competition in this sort of intervention. These are heart boards developed by one of our Million Hearts health centers in California that use the hearts to symbolize 25 patients brought to control for hypertension. It was a good way to get care teams engaged and excited and to help them connect to their day-to-day activities with real human lives. The number one learning with regards to our care teams was how impactful leveraging pharmacists can be in improving blood pressure control. So some health centers had pharmacists their pharmacists conduct peer reviews of charts for patients who remained uncontrolled for a period of time. Others scheduled pharmacy appointments for their patients. And then our health centers who may not have had a pharmacist on staff got creative and partnered with a local pharmacy school program to have students rotate through health centers to review charts. So let me talk about this sort of confusing, busy-looking chart. So this falls under optimizing the use of the expanded care team. Another important factor in getting the most out of people is ensuring they actually have enough time to do the things you're asking them to do. If you decide that your organization is going to focus on increasing care management for patients as a strategy, it not only needs to have the workforce to do this, but the workforce needs to be using their time optimally. So in one of our Million Hearts Health Centers, they conducted a time study and found that patient care coordinators who are a limited critical human resource to do chronic disease care management were spending half their time on prior authorizations. So while you wouldn't normally set out in a hypertension QI initiative to think of a staff time study as an intervention strategy, I would say to you, don't be afraid to consider operational kinds of solutions like this, as they often have far larger systems change impacts that can have positive effects on multiple health targets. This strategy, of course, is helping patients self-manage by encouraging self-measurement of their blood pressure. And some of you may be aware that NAC's current Million Hearts efforts are now centered on self-measured blood pressure. These are all examples of clinical decision support, or what we prefer to say, making the right thing to do the easy thing to do. In all of these cases, the CDS is not an interruptive alert, but information to help care teams work efficiently and effectively. What's interesting about this slide is that these all actually represent the same information. They're all designed to inform care teams that there's a patient with multiple elevated blood pressure readings, but you can see that how it was integrated into their various workflows was very different depending on their internal capabilities and preferences. This final example falls under facilitating care proactively through population management by using registries and other health IT tools. Several of our health center teams use registries based on the undiagnosed hypertension algorithm I mentioned, or on queries for uncontrolled hypertension, to conduct outreach to patients to try to schedule them for appointments. For some health centers, this included trying to engage patients who would come in only once ever to their health center's affiliated urgent care facility, and for whom they were now responsible, at least from a quality data perspective. So my final slide on the HIPS project draws again from our survey of the health center teams, and specifically some advice to others who want to do this work. What's interesting about this list, if you notice, there's actually no mention of blood pressure or hypertension here, because these are tips that apply to any quality improvement effort in almost every health target. So this is learning that has broad application well beyond blood pressure control, but really to all of your Million Hearts targets. So that's all I have. Thanks again for the opportunity to be part of the call today.
Thank you so much, Meg. At this time, Meg is going to stay on with us and answer any questions or comments pertaining to her presentation. So, Karen, I will ask you to share about the conversation happening in the chat and any questions that have been posed. Karen?
Hi, this is Naya, just in case Karen can't.
This is Karen. I was on mute. There was a question in the chat about if Meg might be able to provide a link for the tool that she mentioned to calculate their own estimates of the number of people now with blood pressure control, heart attacks, and deaths prevented.
I'd be glad to do that, and you may, Judy's team may actually have an updated version of that tool, but I'm glad to share that.
Okay, great. If you don't do it today in chat, you can just email it to the MCC team. You can email it to me, I guess, Karen or Nikki. And we have another question in the chat. It just came through from Donna Shanklin. Heart-to-heart texting is through whom?
So say that again, heart-to-heart texting?
She's asking, who sponsors Heart-to-Heart. Is it an app? It's called Heart-to-Heart texting. Did you mention that in your presentation?
So I did have a screenshot of care message. Is that the one that she was referring to? The one that had
I think so. I think I saw that and it said heart to heart also.
Okay, right. So, right, it does. So, that's actually a program that is through Care Message, if she's interested in that.
Okay. Care Message. Is that a software?
It is. It's a health IT vendor, and again, that's something I can follow up with as well.
Okay. Thank you. It looks like we have another question that has just come in. I'm reading it as we speak. With the desirable results from clinical pharmacist involvement you just presented, is there any discussion around CMS reimbursing pharmacists as providers nationally, especially in chronic disease management?
That's a great question that I think is probably better for Cynthia to answer.
I'm sorry, can you repeat that? I was distracted.
Sure. Yeah, I'm not sure we'll know this, but it says, with the desirable results from clinical pharmacist involvement that Meg just presented, is there any discussion around CMS reimbursing pharmacists as providers nationally, I think, rather than the pharmacy as a facility, having the pharmacist be the having PI, maybe, especially in chronic disease management?
Yeah, that's a great question, and I wish I had the answer for that, but that is truly a payment discussion, which I cannot get into, but it is something that I can move forward to the powers that be and see how it goes. The best thing I can suggest is just continue to check the website for issues such as that, but I have no information one way or the other that I can share.
Okay. Well, as far as what's already covered, I do know pharmacists can bill for medication therapy management, so if
right.
they do classify that, they could use that.
Yeah, but as far as that overall, structure, that is a higher level discussion than us. And also, just to get back on the model test, the cardiac rehab model test, I was told that, plans are still on for it. And with a projected start date not until January 1 of 2018, but that is a tentative start date.
This is the conference operator. We do have a question over the phone line from Coleman Pitchens.
Oh, that's the person asking the pharmacist question.
Okay, they here we go. Their line is open.
I was specifically talking about, way beyond FCM, pharmacists, Washington State just passed a statewide mandate that all payer source sources pay pharmacists as providers for prescribing rights. So, with that data that was presented, I guess similar to what was done with the Asheville project, that if pharmacists could manage chronic disease or hypertension patients, then if you have better outcomes, like I said, I was wondering if they were moving more towards that model nationally.
Yeah, that is a great idea, and again, something that we do have a PharmD that is in our area, and that is a question I can pose to her.
Great. We're going to move on now, and so I'll let Lindsay take the floor.
Yeah, thank you so much, Meg and Karen and Cynthia and everyone for chiming in. I'm going to introduce our final speaker. It's my pleasure to introduce Dr. Larry Garber, Medical Director for Informatics with Reliant Medical Group and a previous hypertension control champion. Larry will be discussing hypertension control strategies to engage patients in the community. Larry, the floor is yours.
Thank you. It's really tough to follow Meg with her brilliant work that she's done, but we'll see how this goes. So I'm going to talk to you a little bit about our work at Reliant Medical Group and how we've worked to improve blood pressure control in our population of patients. We're located throughout central Massachusetts. We're a large multi-specialty group practice. We're not owned by any hospitals. No hospitals own us. But what's unique to us is that we've had over half of our patients are in value-based contracts. And to be perfectly frank, what that means is that the higher quality, lower cost care we provide to our patients, the more money we make as an organization. So it's always been in our best interest for decades, actually, to try to be in the top 10% in the nation for our quality measures. So back in 2011, when we looked to see how well we were doing with blood pressure control, in order to be in the top 10%, we had to have 72% of our patients, of our hypertensive patients, under control. And instead of 72%, we only had 68% under control. So we started a multifaceted hypertension control program to try to improve that. And so I'm going to go through a lot of the different strategies that we did to improve our blood pressure control. So right on the front line, we tried to make it easy for patients to get their blood pressure checked. We had nurses running free blood pressure clinics and also doing one-on-one office visits for patients for free to work on their blood pressure. And we set up protocols, as had been discussed earlier, on how to titrate the medications to control the blood pressure, and empowered the nurses to do some of that titration right there directly with the patient. I'm going to talk more about those protocols later. We also had our staff use digital blood pressure cuffs. We found that with the regular analog cuffs, they were doing a lot of rounding and we weren't getting accurate measurements. And then the other thing that is probably one of the most important interventions was actually making alerts, as you saw that Meg had done, in our electronic health record to jump out and hit us over the head that here's a patient whose blood pressure is not well controlled. And so for the medical assistant who's checking this when they're putting a patient in the room, this would alert them that they need to let the patient sit for 5 to 10 minutes and check it again. And then it's also for myself as a primary care physician to see, oh, wait a second, after several readings, their blood pressure still is not controlled and I really need to do something about it. So it's very important to really take advantage of the power of the electronic health records. On the back end, we were actually monitoring the compliance of the staff, of the medical assistants, with taking those second and third blood pressure readings, and we would give them feedback, letting them know which ones were not following the guidelines that we had laid out there. We also gave physicians and advanced practitioners feedback as to how well we as individuals were doing, and as a site how well we were doing compared to other physicians and other sites. And that competition really helped drive each of us to pay even more attention to this when we realized that maybe we weren't the best in the organization. We also did queries across our population to find patients for we have our own PharmDs, pharmacists that could help with patients, and we looked for hypertensive patients who, for instance, had poor control and were diabetics and had not been on good medications specifically designed to treat them. And they would send advice to the primary care physician suggesting that perhaps we consider trying these medications. So again, working as a team really made a difference, as I'll show you later. We also wanted to make it easy for patients to take their blood pressures at home, so we did self-measured blood pressure, but we did it in a way that was truly convenient, in that it wasn't just a matter of having the machines at home taking their pressure, but we didn't want them to then have to get on the phone, call in a dozen readings to us, have someone on our side transcribing a dozen readings into our electronic health record. It's really not convenient for anybody. So we set up a system. We've had a couple hundred patients do this, where their home machines would automatically send their readings directly into our electronic health record. And this is common to many electronic health records these days, this functionality. We used it through an online system called Microsoft Health Vault to make the connection, but a lot of the systems, including ours, are also able to use smartphones to connect to the home blood pressure monitor into the electronic health record system. And when you set this up, you're able to set guidelines so that you don't get every single reading generating a message to us, but you're able to batch readings in a group so that maybe every 2 weeks we'll get a summary of all the readings that have been loaded and what their average readings are. We also set parameters as to if it's critically high or critically low. I want to be notified immediately when those are uploaded to us. And we were able to configure the system so that instead of the messages all coming to me, they would actually come to my nurse who could use those protocols to do some of the titration. So again, working as a team is very efficient. We did have some lessons learned by using these devices. You need to make sure you're using good ones, and that you also validate them in the office to make sure that they're not defective and that they actually do get accurate readings, comparing them to machines that we have in the office. Also, most of these machines have a date setting on them. So we would first put the battery in and set the machines up for the patients and make sure that the date and time were set properly, because when you upload a reading, it's coming in with the date and time that's on the machine. And what would happen is that eventually the batteries would run out, the patients would put in their own batteries, and they may not reset the date and time. And as a result, we would sometimes get readings that looked like they were from 5 years earlier. And we actually had to update our system to account for that and notify us when there were these incorrect dates, and we would contact the patient and let them know that they need to set the date and time on their devices. We also had issues where some of the devices were shared with multiple family members. You have to be careful to make sure that you're uploading readings from the patient and not their spouse. We also put a lot of effort in making sure that we are promoting medication adherence, and we had a lot of strategies around that, and I'll go through those. First and most important is to make sure patients understand what's wrong with having uncontrolled blood pressure and what are the benefits in terms of their health and their life expectancy and quality of life by controlling their blood pressure. So we have a lot of ways to make sure that they understand that. We have trusted information that we put on our public website. We also automatically put on their after-visit summary that is available right after the visit, both in printout and online. If they have a diagnosis of high blood pressure, it automatically lists some important information about high blood pressure and how to control it. And then we also, as you can see in this picture, we make our monitors, the computer monitors in the exam room, easily visible to patients so that they can be, we can show them graphs of how their pressure and their weight have been doing, whether it's good or bad, and that gives them visual feedback that's very easy for them to understand. You also want to make sure that you're picking medications that they can afford. We try to focus on lower cost medications. And so the protocols that we developed were focused to make sure that first-line therapy is going to be medications that are less expensive, that they're generic, and easier for them to pay for. And also, as we'll see in the next slide, easier for them to take. So the pathways were developed through a multidisciplinary team with nurses and physicians and cardiologists and nephrologists and primary care physicians, all working to come up with some protocols. And they're available. There are other protocols that are available online now that that are great to work off of. But as an organization, we agreed that this is what we're all going to do, and that we're going to allow our nurses to follow some of the basic pathways in these protocols. We also limit the marketing from drug reps. So it's been a decade. It's been several decades since I've actually seen a drug rep because of these policies. We also have in all of electronic health records now. You typically can see the formulary information so that you know which medications are less expensive for patients if you do have to go off the protocols. And in Massachusetts, pharmacists are required to substitute generic drugs, but that's apparently not the case in all states. The protocols were also great to make sure that we chose simple medication protocols, meds that patients could take once a day, and also combos, so it's fewer pills. The more pills, the more times a day, the less likely they'll be adherent with them actually taking it. It's good to have discussions about patients, about what's more important to them, because sometimes we can save them money, for instance, by splitting pills in half, but then that's harder for them to do, and it may be that they'll be less compliant, even if it is less expensive to cut in half. So that's important to really discuss what's important to patients. We also have websites that we offer up to patients if they need assistance in getting medications, and those websites are on the slides here. We also have our own social workers. So in tough cases, I could refer someone to a social worker or our own pharmacist to see if we could help them with financial assistance or maybe less expensive drug regimens. It's important to monitor the side effects. A lot of these medications for hypertension make people tired, or they have some sexual dysfunction side effects. So really it's important to talk to patients about these side effects and to monitor those side effects. And we actively do that during the visits. And then also we, again, consult our pharmacists if they have, if there's side effects that we need their help in trying to control. We also monitor medication adherence, which most electronic health records can do now through SureScripts. The electronic computers can integrate with the pharmacies to see not just that we prescribe the medication, but each fill that the patient has done. So, for instance, the graph here, you can see, this chart here, you can see that a patient has picked up their lisinopril every single month, right on schedule. They're getting 30 pills. And since this is one pill a day for them, they're actually right on schedule. But if I see that their pills are lasting 45 days or 2 months, I know that they're not taking their medications every day. And the fact that I can tell this to my patients and say, look, I know you're not taking your patient pills every day. Why is that? It allows us to, first of all, figure out strategies to make sure they can take it every day and to understand why they're not. But it also knows that we're watching. They know that we're watching, and that really motivates them to pay attention because they actually don't like to disappoint us, which I've always been impressed with. So letting patients know that we're watching is sometimes even more important than actually watching. And as a result of all this, we went from only being compliant about 60% of the time, only having blood pressure control in 68% of our hypertensive patients, up to almost to over 80% control in our hypertension population. And with that, thanks to CDC and the Million Hearts program, we were recognized as a 2015 hypertension control champion, which we're very thankful for, but we're also thankful for the improvement in the health of our patients. So where do we go next? We really think that there's room to expand the team. Our team right now has, we've got the physicians, the nurses, the pharmacists, the social workers, and medical assistants. And we'd like to be able to expand that out into the community to take advantage of community resources at the Y or senior centers or religious or cultural centers to expand, and the federal government to expand the education that we give to our patients to help them learn how to control the blood pressure better, to help them learn how to use home monitoring devices. And we think that there's a lot of opportunities there to expand that. So in summary, educate and empower your patients, get them monitoring their blood pressure, make it easy to do for them, make it easy for them to do the right thing, work as a team, don't expect physicians to do everything. And in fact, if physicians don't have to do much, the team is really important. Promote the medication adherence and let patients know that you're watching and expand to the community. And with that, you can be successful as we were. And I guess we can take questions now.
Yes, thank you so much, Larry. It was a great presentation. So at this time, we will open up the call for questions and comments for Larry. Again, Karen, I'll invite you to share about the conversation happening in the chat and any questions that were posed during Larry's presentation. Karen, are you on mute again?
Yes, ma'am, her line is on mute.
Okay, this is Karen. There is one question in the chat. Lindsay, would you like to remind everyone how to get to the phone queue in case someone's wondering? Lindsay, can you hear me?
Oh, sorry. Did you say there's no questions in the chat?
There is one question in the chat, but I thought maybe you want to remind people how to get into the phone queue.
Oh, sure.
Phone questions.
Yeah, the slide is up right now. So you press star and the number 1 on your telephone keypad.
Thank you.
Sure.
Davidin asked if someone could provide a list of brands or suppliers for the type of blood pressure machines that link results directly into EHRs.
So actually, I'll take that. So it's not, I think what you need to do is talk with your EHR, our vendors, because each has, they have different mechanisms for doing it. Some work with USB, some work with Bluetooth. So you actually have to go to the EHR vendor. Our EHR vendor it makes it possible to use Bluetooth as well as USB. So for our study, just so that you know, we use the Omron blood pressure cuffs that connect via USB. But there are many other good brands and mechanisms out there. It's based on the EHR vendor.
All right. I think that answers it well. Thank you, Dr. Garber. Here's another question that just came in. Donna Shanklin asks, what is the mission of the Reliant Medical Group, and why is there no affiliation with the hospital, et cetera?
Well, so, as I said, we're a large multi-specialty group practice, so we have about 30 different specialties represented, primary care specialties, medical specialties, surgery, and our mission is probably the same as probably every other healthcare organization, is to provide the highest quality care for our population of patients. We're actually a not-for-profit organization, and we care for about 300,000 patients in central Massachusetts. But while we're not owned, and we don't own any hospitals, we certainly, I guess, we admit our patients to hospitals. We have hospital privileges. We had one of the first hospitalist programs in the country where we had dedicated internists working in the hospital to care for the patients throughout the day. So we do work with hospitals, and we have significant electronic interfaces with the hospitals. And in fact, we actually load every test result that's done during the hospitalization and all the notes back from the hospitals into our electronic health record system through interfaces that we've done with them. So in that respect, we work very closely with hospitals. We're just really not owned by them. And to be honest, our goal is to keep people out of the hospital. We want to keep people healthy, and if they go to the emergency room, that may be considered a failure.
Okay, great. And they are a ACO, right? Reliant Medical Group.
So Reliant Medical Group participates in, we're in one ACO right now. Next year we'll be in another ACO, and we also participate in Medicare Advantage. We have value-based contracts with Blue Cross and the other payers in the area. So we're not per se in our ACO. We're part of, many of our patients belong to ACOs.
Okay. All right. We had a question earlier that was really interesting, and I know Cynthia was working, she was looking into that to it, but someone asked about why aren't and this could be for anyone, why aren't self-reported or self-measured blood pressure counted in the QPP as a blood pressure measure? And I'm not even sure that that's the case. I'm not sure. If you enter a blood pressure number into the person's EHR, whether it's self-measured or clinic measured,
technically, unless you actually know that, and if the clinician entering it through that EHR, or if there is no way of us knowing on our end, with the QPP program or formerly PQRS, where that blood pressure comes from, if it comes through the EHR in some way or through a registry or, technically that may not be an issue, but, I think the assumption is on CMS's end that blood pressure is taken by the clinician in some way. But again, that's not part of the specifications. It's something that, we can take forward just to make sure, how is that, seen on our end. But I can tell you that if it's entered through the EHR, whoever is entering it and whoever took it, we don't know that information.
This is Larry. I can add one more thing, which is that in general, blood pressure readings that are done at home on average are 5 points lower than blood pressure readings done in the office. And so most of the studies are done with office readings, and so your goals should probably be 5 points lower if you're using home readings. And so as a result of that, when we load the readings from the home blood pressure monitors, we actually load them in different fields than our own office-measured blood pressure because of that known 5-point difference.
And that is a great idea, Larry. And then I think someone else asked a question about are home blood pressure monitors covered by Medicare? And the answer is yes and no. The blood pressure monitor and stethoscope for patient receiving blood dialysis in the home is covered. And then also it can be covered for an ambulatory blood pressure monitoring device which takes and stores the blood pressure readings in 24-hour cycles. And I'm just reading to you exactly what the coverage determination says. And it says, which takes and stores blood pressure readings in 24-hour cycles for a patient who a physician believes has white coat hypertension, unquote, artificially high blood pressure readings when taken in a doctor's office based on repeated in-office and out-of-office testing. So there's some criteria that go along with that. And then if it is covered, deemed covered by Medicare, once it goes through the process, the payment process, Medicare Part B will pay for the rental of the blood pressure monitoring device, but only if rented from a Medicare certified medical equipment supplier. So those are the rules that are followed. And I continue to the link so you can read. It was a national coverage determination decision that was made on that.
And this is Judy. I'll add on to what Cynthia is talking about. So the guidelines that are out there related to diagnosis of hypertension, ambulatory blood pressure monitoring can be covered. But in general, as far as coverage for treatment, it's not yet covered. There are some insurance companies that are covering it. Most of them are also covering it for diagnostic purposes to rule out white coat hypertension, but there usually isn't any adjudication about why somebody got the cuff.
Thank you, guys. That was very helpful. Very helpful to everyone who chipped in on that. Does anyone else have a question? Lindsay in the phone
We
line.
do have some questions on the phone line. Your first one comes from Linda Biebert.
Hi, Dr. Garber. I am a parish nurse or faith community nurse, and we are community partners stopping blood pressure screenings in the churches. So if you haven't done so, to reach out to your faith communities, and parish nurses can help with education and screening patients' blood pressures in the community.
Great idea. Appreciate that.
Your next question from the phone line comes from Allison Ishihara.
I was wondering if there are any programs that are out there that can help a patient to get a discounted blood pressure monitor as opposed to the insurance covering it completely, if there's any manufacturers that are offering discounts.
This is Judy from CDC. To my knowledge, I'm not aware of any national or large program. There are some pilot efforts that are going on in different states and different regions where there might be some, but I'm not aware of any national effort from a manufacturer. We are doing what we can to be reaching out to the manufacturers along those lines.
Thank you.
Do we have any other questions on the phone line?
No, ma'am, we do not.
Great. We are right at the end time, so we're going to wrap up. If there are any other questions that people have, please feel free to submit them in the chat box. We'll post any responses to unanswered questions, if necessary, on the QIO program website, which Karen has referenced a few times during this call. Upon closing the WebEx session, you will also be invited to share your thoughts and feedback for a post-event assessment, and we really value this feedback and appreciate you taking a few minutes to complete it. As a reminder, a link to the evaluation to claim continuing education credits can be found at the end of the post-event assessment, so you will have to go through that assessment to get that link. I'd like to thank all of our speakers today, Cynthia Panlin with CMS, Judy Hannon with the CDC, Meg Metter with the National Association of Community Health Centers, and Dr. Larry Garber with Reliant Medical Group. And of course, thank you to all of our participants for being with us today and asking great questions. Have a great afternoon.
This concludes today's conference. You may now disconnect.